All right, I think we're gonna go ahead and get started. So thank you everybody for attending our ANST NeuroTech talk of this year. This is our first one of this semester. Today we're excited to have Dr. Kelly Norel today. She is a research scientist, a staff scientist with IBM, with specific expertise in AI-driven language analysis in health conditions. So we're very fortunate to have her here talking about her work. So we're excited to hear about her work and ask her questions at the end. Thank you, Dr. Norrell.
Thank you very much. Let me find my PowerPoint and share it. Okay. So do you see the presenters mode or I need to switch displays?
We don't see anything yet.
You don't see anything yet. Okay. You're right. I need to share. Yeah, but I'm not allowed to share. How about that?
I just gave you privileges.
Okay. So which screen do you see?
We see your notes,
Okay.
like the presenter view.
Now it's fine? You see
Yeah,
the big
now
one?
it's good. Yeah.
Fantastic. Well, I don't know if Shifali is or not on the audience, but anyway, thanks to Shifali for inviting me to present what we do at IBM using speech, in particular in digital health. And we focus mainly in mental conditions and neurodegenerative conditions. So I will give a little bit of introduction why we do what we do. And then I will go in some detail in one project, then I will just show a little bit of a few others, and then go in more detail in another project that's related to what we're doing with Shifali. And then I will tell you about a new project that we are just starting, so you know where we're going. And again, please feel free to ask questions, but I don't see if you raise your hand or anything. All my screen is on the presentation, okay? So I'm sure you are also familiar with this situation when they ask you, how do you feel or how much pain are you in on a scale from whatever to whatever. The issue is you don't know, no one knows. Is my 3, is you are 2 or you are 6. We don't know if you are tired, your numbers change. And also depends who is asking you the question, how will you respond? So we know that this type of self-assessment has plenty of biases that we want to avoid. And if somebody has pets here, we have another version of the same drawing. So in order to avoid having to ask to the person, what is your pain or how do you feel or are you depressed or whatever, and giving some scale, we use speech as a window to the mind. Usually we will ask some open-ended question. So the person will tell us either a story or answer some narrative question. And we extract acoustic markers, linguistic markers. This type of data is very easy to collect, is scalable, is cheap, right? So we use speech, which is a dynamic expression of thoughts and emotions. Speech provides linguistic markers of neurological and cognitive states. And we have used speech as a diagnostic tool for disorders like Alzheimer's and Parkinson's. And also we use speech patterns for early detection of cognitive decline. In general, we use NLP, that's natural language processing, and machine learning to identify cognitive impairments, among other things, right? So we have a lot of work in neurological conditions, in particular ALS and Parkinson's. We have work in psychiatric disorders, again, in particular with the schizophrenia and depression, and a little bit less on suicidality. We also have some work in, again, based on an interview of the person, on speech of a person, if the person has taken some psychoactive substances, we not only can tell you he is with or without the drug, but we can tell you if it's a high or low dose. And again, all what I'm presenting, I'm happy to send you the papers if you're interested. And also we have work on chronic pain, on metabolic diseases like PKU. That's a work with Shifali. We can measure emotional states, and now we're working on mapping surveys from, again, open-ended interviews. So let me start with this work on Parkinson's. So we had this work was with Pfizer, and well, they wanted to test a new drug. So before we were using something known, like to check if our methodology works or doesn't work. And we will have the patients twice. One, okay, I'm not familiar. I don't know if you are familiar with the levodopa and the effects on Parkinson's patients, so I will give you a little bit of that information. So patients with the advanced Parkinson's, they cannot control their tremors, for example. So they're giving levodopa to minimize those symptoms. The problem is that depending on what you ate and when you eat, and also on how you metabolize the drugs, levodopa doesn't last the same for everybody. So it's not like an antibiotic that they will say, take it every 8 hours. You need to know when to take it. That is when the previous dose is starting to wear off. So, and it's a known fact that when they compare healthy volunteers or controls to people with the Parkinson's, the people with Parkinson's use less physical action words. And that's a known fact. So I thought to myself, okay, I think it's because when they ask the controls, for example, what did you do over the weekend? They will say, I went for a swim, I went to play soccer. And when they ask a person with Parkinson's, what did you do over the weekend? They will say, oh, I watched a movie, I read a book, I took a nap. And here we are using the person in the on state, that is when they are well controlled, their motor symptoms, as if you want the control, and the off state is a person with Parkinson's. And so in order to check that this was really true and not a case of how was the question proposed, we had randomized. Half of the patients came in on state, that is, they have just taken the drug, the first session, and the other half, they came when the drug already wore off. And everybody described this picture, the one to the left, first. And then in the second session, that was on a different day, the person that has coming on this time was in off, and the ones that were in off the first time were in on this time, and everybody described this picture. So now we have a balanced set where they describe, in a sense, the same pictures, but in the on and off state. And when we compare, we effectively recover the fact that people in the off state use less function words, action words, less physical activities to describe the same thing for everybody. So then we recover the fact that motor function influences cognition, and now you will describe something. Now, we have worked for many, many years already with different institutions on ALS. I don't know if you are familiar with ALS. It's also known as Lou Gehrig disease. It's a neurological condition and is diagnosed by elimination. That is, there is no one test that it will say, hey, you have ALS. They will start testing for many things and they rule out many things. So it takes very long, a year or two to diagnose. The problem is once you are diagnosed, most people die within 2 to 5 years. So it would be good to be able to diagnose earlier, because I think part of the reason why all the clinical trials have failed is because the persons are already very deteriorated when they get diagnosed so they can get to a clinical trial. Somebody told me it's the equivalent of a cancer person being diagnosed as stage 3. Not many drugs will work in that case. So here I will show a little bit of what we did. So we have a cohort of patients with ALS. Now, ALS progression is measured again with a questionnaire. Sometimes it's self-administered. It's called the LSFRS-R, and it consists of 12 questions, each of them with a score between 0 and 4, where 4 is normal function and 0 is you cannot do it. And so one of those scores is the speech score. They ask you, how is your speech? And if you see with our inference modeling, we get to pretty good Pearson coefficients for the inference. We have 3 tasks. The person were supposed to count until they were out of breath, but and that in a sense is a proxy for how your lungs are working. But when we listen to some of the outliers, you will hear the person breathing the middle, because they don't want to, I guess, acknowledge that they can count so little before needing to breathe again, right? These people is only deteriorating. Another task, they were asked to describe a picture. And the other task was they had to read the bamboo passage. That is a passage that contains all the sounds in English and is widely used for people with the issues with the speech. So this first we publish only our part of the study in a conference, and then was part of the bigger study when they also did some wet lab in Nature Neuroscience. Now, something that is not usually measured in ALS is cognitive impairments. Now, an important proportion of people with ALS also develop FTD, frontotemporal dementia. And the problem is if you have both, you die much faster. It's not known if it's because the person doesn't want to take care of themselves or it's harder for them to take care of themselves. So it's important to be able to diagnose these issues with cognition to have, if you want, a more aggressive either treatment or a support system. So there is a special test to check for cognitive impairments. It's called ECAS. Why they cannot do the regular one? Because, for example, if you ask them to draw the clock and they cannot draw, maybe it's because they are unable to grab the pen, right? Remember, these people have neurological issues. They cannot control, well, breathing, arms, or legs. So what we do here is the person is presented with a online version of the ECAS test. So before was given only paper and pencil, But since we want to do things remote, for these people it's hard once they are advanced to go to a clinic, to go to an office. They have a lot of issues with mobility. And also if you want to scale it. So there is an online version of the test. And then we also ask them to describe a picture. We transcribe this picture description and we extract different types of features from psycholinguistic intelligibility, that is, how are these for a software to understand what they're saying. We measure the physical action words that I told you from Parkinson's. And we also have some measures that are based on graph that we build based on each node is a word that I mentioned, and there are edges if they are consecutive words. And then we measure things that describe those graphs. And we also have the acoustic features. And with all this, we do linear regression models and we infer the performance. And again, we get pretty good results, low p-values or okay p-values. The cohort was not very large, but was like a first test. And different, so the ECAS has several modules, and at the end you have one total score, the addition of all the subscores. Each of them was best characterized by one of the type of features. So at the end, we have to use them all to get the best performance. Now, continuing with the ALS, as I was telling you, it's very important to be able to detect as early as possible ALS. So in this case, we want to differentiate what we call pre-manifest from manifest for the speech point of view. So we are calling pre-manifest to people that in the report, how is your speech? They give themselves a 4. And manifest people that give themselves less than a 4, right? And you see that the software is able to differentiate between manifest and pre-manifest, meaning even when the person thinks that their score has not been affected, the software is able to detect differences, pointing to being able to differentiate early impairment. Now, this is I just submitted today the revision for this paper is under review in MPJ Digital Medicine. So here we are doing a model that it doesn't use handcrafted features like the ones I was using before, but we use what's called an end-to-end model. But this one is interpretable. So it's not that we're choosing a black box over something that we can give some interpretation, because we use attention focus maps. So first, let me start with the gold standard, because you need a gold standard, some annotation to be able to train a model and to then check how well your model is doing. So 3 speech language pathologies were rated some audios, 3 sentence readings per person, per session. And they had to say how hard was to understand them in a scale from 0 to 100. 0 is no effort, 100, I couldn't understand. Now, we noticed that sometimes 2 of the raters had close scores, but the third was far away. So we are only using the 2 scorers that are closest, and we are discarding the third. Maybe somebody misinterpreted the scale, and instead of thinking that 0 is no problem, so 100 is a problem, so we decided to discard them. And now, if the two closest one have more than 10 points distance, we also discard them because, I don't know, you can be distracted or something happen, cannot be so much difference as 10% on the scale. So we have a gold standard as the average of the two closest one. The person reads a sentence, we have an audio. That audio is transformed as a spectrogram, and that's only a visual way of displaying the audio. And these go to one of these transformers, these big language models. And at the end, there is a classification head that is predicting the listener effort score. But not only that, we can, in the last layer, we can see by the weights where the model is paying attention. So you see the dark marks is where the model is paying attention to make the predictions. And with that, we can map back to the spectrogram and then to the words. So we notice, for example, that an inspiration, taking air, is an important aspect for the model, and some words also are more important than others. Now, you can see here, this is the gold standard, and this is the inferred score. You see that the model is giving a little bit less score than the true one, but in part is because since this project is to be focused in early detection, first of all, the controls are in this corner, and also many of the patients also are in this corner, meaning it's easy to understand them. So we have better training in this part of the plot than in this part, right? And as you can see, different words or different sounds are more frequent than others in being important for the model to make the inference. So our approach is an AI model that enables precise interpretable assessment of dysarthria from remote speech, supporting disease monitoring in ALS and other neurodegenerative conditions while reducing barriers to care. Okay, now I will show you a little bit of some results on our work on mental health. So in this top panel, I'm showing a paper that we did with interviewing mostly veterans that have schizophrenia. And also we had some controls and we had some civilians, but most people were veterans. And they were asked many questions, but we only analyzed the results of the question, tell me about your life. So it's a very general question. It's the same one for controls and patients. And we were able to find something that is very, very different in the group from controls from the people with the schizophrenia, and is the lack of agency. And then here we have another word that is, I don't know if you're aware what's CHR population. So this is youth that are in high risk for psychosis. They have a subthreshold psychotic symptoms. So the idea is if we can identify who will convert to have psychosis, you can monitor them closely, you can medicate them before. So it's an important population to follow up. And we have done some work in a cohort that the interview was conducted in English, but then we also got access to some interviews that were conducted in China in Mandarin. So the culture is very different, the language is very different, but we were able to find that the markers for psychosis are universal. Now, another study we did with mental health, this was people that arrived to the ER the mental health ER in a Northwell hospital. So can be people very depressed or people with a psychotic episode or trying to commit suicide or something. They arrived to the hospital and they were asked if they can provide us with their Facebook page account. And we analyze both the images, the photos they posted, as well as the messages they posted. Not what was posted to them or answered to them because we didn't have that consent. So it's only what the participant is posting. And what we found is that even a year and a half before the hospitalization, we still were able to identify difference between the healthy controls and either of the populations of patients, or even differences between depression and psychosis.
Dr. Norel, what were those differences?
Okay, so in the pictures, we're seeing as the width of the picture, the height of the picture, and I may have a diagram for the, let me see if I have the diagram for the differences in language. Let me see if I have it here. Yeah, I have it here. No, let me see. Okay, so I'll tell you later. I don't have the graph here, but I will. Okay, so this one is and I don't remember, this was a few years ago, but for example, in the, let me see, where is my share here? Share. Yeah, this one. Continue to share. So just again, you are in the right screen, right? I am in the right screen, correct?
Yes.
So for example, people with controls use more contrast in the photos. So the pictures are more clear with more contrast. And have you heard about that they call people with depression like they are having the blues? Well, I don't know where is that coming from, but when you analyze the hue, that means like the colors that they use, people with depression use cooler colors, so closer to blue, that when compared to controls or people with schizophrenia. And again, the width and the height of the pictures were smaller for the patients. But what we don't know, we couldn't know if this is a real feature or if it's a fact that they have maybe worse phones, worse cameras, right? And then I can show you um, I need to look in another file, but I will find it, the one with for the language. I don't remember by heart. But for example, people with some of the patients use more words like they sense smells or they sense sounds. So people with psychosis, they are much more sensitive than and people with the depression, they use more anger words, swear words. But I'm happy to show the plot in a couple of minutes.
Thank you.
Let me see where I was now. Where was I? So I was here. Yeah. Yeah. Okay. I need to share again. Okay. So now I'm going to tell you a little bit about our work in PKU and LLMs. So LLMs is large language models. PKU is phenylketonuria or something like that. It's a metabolic disease. And what's interesting is this person, Susan Weisbrand, has worked for all her career with people with PKU. And she told us before we started the study, when I speak to them, I notice there is something different in their language. They speak, there is something odd, but I cannot measure it. I don't know what, all the tests I do, nothing shows me what this is. So I say, okay, we will give it a try. So this PKU is a rare genetic disorder that affects how your body processes phenylalanine, one of the amino acids, and it doesn't get translated to tyrosine. So when phenylalanine builds up in our blood and pass to the brain, that can cause intellectual disability and also other neurological issues. Now, every baby that is born in the US and many other countries, like before an hour they're born, they take a drop of blood from the heel, and they do a testing to see if they have this PKU or not. If they detected that they have PKU and you start them in a special diet that is a very low protein diet, you really minimize the effects, but it's a very hard to follow diet. And now there are a subtle difference in speech between individuals with low versus high phenylalanine, meaning well-controlled or not so well-controlled disease, okay? So the idea was using the cookie test. Is the same picture we already saw and we will see again. They asked them to describe the picture. The first task is, can we differentiate people with PKU from controls? And then can we somehow correlate the Phe level in blood to some of our metrics? And then can that also be correlated with some of the traditional neuropsychological metrics that you do with the regular testing? So here you see, in general, the cohorts are very similar. The only thing is that the group with PKU, in this case, is more often employed and married than the controls, but that's really not the case in the PKU population as a whole. So in particular, people that go to these type of studies are well controlled and not necessarily represent really the whole population. So people with PKU, when compared to controls, have lower employment rates. It's hard for them to maintain long-term relationships, and it's hard for them to live independently. Now, this is part of I'm sure you are familiar with this type of test. It's very routine. The only difference, and again, you can say is borderline, is that if you want, barely any difference in the test for people with low or high phenylalanine. So this is our pipeline. We will extract our linguistic features, the ones we use for all our projects, and we will use the labels, so it's supervised, to get some features that can differentiate non-PKU from PKU. This group of features we will do now unsupervised, something called MDAs, that's multidimensional scaling. So because we have here 23 features, we cannot imagine or cannot plot 23 dimensions. So we want to use 2 dimensions or 1 dimension. And this we can then plot and see correlations with the Phe. So what type of features we extract? For example, we will build something called syntactic parse tree. where you extract the part of speech, that is how many verbs, how many nouns, what's the proportion. Also, you see some plots have more depth than others, so that shows the complexity of the language. We also create something called dependency graph, where the words are nodes, and we put an edge if the words are consecutive, and then here we can check for repetitions, loops, coherence among consecutive sentences, for example. So here are the features that are different in PKU and non-PKU. So for example, did the person mention water or girl or boy? We use something called semantic similarity. So you can say, I don't know, sister or little girl or schoolgirl or something, and we check against girl, right? But also is the amount of part of speech, the amount of pronouns, etc. Now we wanted to check after doing this multidimensional scaling, and that's only pure mathematics. So no labels, nothing. We went to 23. Show me where you have the most difference. And when we do the cumulative distribution, the CDF, we show that the groups with high phenylalanine and low phenylalanine are very different. They are very separated. So we went from, in this case, 23 features to 1, right? And without passing any information regarding the level of Phe on blood, we are able to get these results. I think shows that this MDA is functioning. So then we wanted to understand what means this dimension, because there is the problem with this dimensionality reduction is very hard to interpret those results. So here I ask ChatGPT if I am, some people is talking about cold, and on the other extreme, some people is talking about heat. How do you call that axis? Temperature. And we want to do the same, but now I will pass you people that have low MDS and people that have high MDS, but I didn't tell him which group is what. So I told them group A, and I passed the 3 descriptions with the lowest MDS. And for group B, I told them I passed the 3 descriptions with a high MDS. And then I asked ChatGPT to show me differences. So one of the differences is that the complexity and depth of description. So for group 1, the descriptions are disconnected, brief, sort of a supermarket list, if you want. The detail orientation is also different between the 2 groups. Group 1 being basic descriptions, only what's visible, missing anything subtle. And the coherence is also very different. So this group 1 lacks the sense of flow or storytelling. Now, when we plot the Phe in blood with this dimension 1, we get a very good correlation, rho of 0.5. So the interpretation is that the difficulties appear to be related to weakness in cognitive rather than language domains. We have issues with attention to detail, clarity, cohesion of expression, awareness of context, and recognition of emotion and activity elements. So that's why we call this MDS1 as proficiency in verbal discourse. Now, the main point here is that this is showing you how, with the help of AI, we can quantify something that is meaningful and can help in everyday measurements for these people. So we need to validate in a bigger cohort, but maybe this can be used in other disease and incorporated in clinical trials. Now, in this journal, they are doing something called visual abstract that I know was my first, and I think it's pretty cool. And you see here, in essence, you have the description of what we did and what was found. And now I'm going to tell you a little bit of, so I have time for answering questions, is what we are doing now. We started a grant that is a multi-center grant, many years, many places. Some of you are here. It's called Predictor. And the motivation is, can we help to predict without an intervention what needs to be done to capture who is going to be in trouble in the future? So here, everybody that enters a new patient for mental health care, either through with a psychologist or a psychiatrist in Mount Sinai, they will get, if you are between 15 and 45 years old, you are given the option to enter the study. And the idea is they will record every time you go to the psychologist or psychiatrist, and you will wear a watch that an app in your phone that captures where are you in GPS, but also how much are you using the phone, if you are on the phone at 3 in the morning, that type of things. And the idea is, if we can predict within a year, is this person going to be hospitalized? Is this person going to be in the ER? Or will they stop treatment? I mean, abandon treatment, right? If we find some markers, those will be actionable markers. You can have impact in the lives of some persons. So this is the approach. The person comes to the clinic. There is a recording for the patient and for the clinician. They also get this app in the phone. We get the geolocation. We get different things from the phone again. And that's the study. We're just starting that. The first patients recruited last week. Now, since we don't have data yet, we want to start playing to what we're going to do. So we're using other data sets in the meantime to start building our scripts, our code. So this is a study that is focused on people with schizophrenia. There are two different studies, people from SPEAK and people from AMSCIS. And using Llama 3, that is a very large language model and one that you can deploy locally on your computer. I mean, not in your laptop, but we have a local copy, maybe you can have a local copy, etc. So the data is not flowing on the web. And the instruction to Llama 3 was, tell me the 4 scores for SOPs, right? The prodromal symptoms. And you get that for both positive and negative symptoms, you get a good R and good p-value. Now, this is a work I'm doing with Paul Guieja in Rochester University. We have a cohort of patients with chronic low back pain. Some patients have depression, and we have healthy controls. And again, I'm using also Llama 3, and the instruction I told the model was, you are a psychiatrist evaluating a patient's emotional state based on an interview transcript. And these persons were asked when they came to the interview, tell me about your life, tell me about a recent event with family or friends, tell me about a dream. So very general questions. And also one question is, tell me about, and depending on which cohort you are, where your back pain started or where your depression started. And I asked for these 6 scores, 3 on pain and 3 on mental health, if you want, except for quality of life, where a bigger number is better. For all the others, a bigger number means you're doing worse. Now let's focus on the top panel. Those are pain scores. So let's start with the green. Those are controls. We see they have very low values. Now, if we go to total pain, so pain in general, the two type of patients have similar scores. If we go to physical pain, patients in blue with chronic low back pain are doing much worse than depressed people. If I ask for emotional pain, people depressed do much worse than people with back pain. If we go to the bottom panel, if I ask for depression, I recover that depressed people do much worse. If I go to quality of life, and for me this was a little bit of a surprise, depressed people do worse than people with chronic low back pain, and of course worse than controls. And no surprise here, for the score of anxiety, people with depression do worse than people with the back pain. Now, those are my slides, and I'm happy to take some questions. And let me look in the meantime for the picture I said I will show. So do you have a question?
I think this is all very exciting. Thank you so much for sharing. I know a lot of this research that's coming out is new and just in development. How long do you think it might be before this is practically rolled out and can be used more generally in the general population? Do you think it's years and years? Are we closer than you think? What is your
No,
sense on that?
I think we are pretty close. I mean, there is a lot of more and more people is doing it. We are getting better results. So it's just a matter of funding. And again, with these big grants is helping. I think we are very close. So we will see it. Okay, let me share once again. Let me share once again. This one. Okay. So you see here, for example, this is a plot, if you want, on language, right? So people with the depression talks much more than controls in bioprocesses, so they're more worried about the body and bodily functions. Both type of patients speak much more about their sexual wants and needs than controls. Here, negative emotions is more pronounced in people with depression. Swearing is more pronounced in both type of patients and controls. Same with anger. Perception, words as I was telling you, smell, hear, etc., is much more pronounced in people with schizophrenia than the rest. They also speak more than about family than controls. It's not statistically significant with people with depression. And if you want more on the form and not on the content, people with the schizophrenia use a more informal, some more slang or like things like LOL or, not really a formal language. Then things that we recover that are being known for a while, that people with depression use much more the I. They're more focused on, they're centered on themselves. These type of things are the differences. Did that answer your question, Ross?
Yes, thank you, Dr. Norel. That's really fascinating. A question we always like to ask our speakers is, what do you think is next for your area of research? What are you excited about with kind of seeing in the future with the methods you use?
Okay, so from 1 year to the next, the tools are so much more powerful that, I mean, compared to what I am doing now with 3 years ago, I couldn't believe it. So, for example, that plot of the levels of pain from an interview, let's say it took me, I don't know, an afternoon to get those results. Imagine you can use it for triage patients. I'm sure you are aware that there is not enough psychologists or psychiatrists in the US, but in general in the world. So imagine you have a lot of interviews that are, a bot can ask you the interview, or you can tell the person, tell me about your life, and then you transcribe it automatically. You pass it to this, and the bot will tell you, hey, try to see this person before that one because he's in a worse state. So that for me, I think that really can have an impact on the life of some people.
I also
Absolutely.
had a follow-up question in regards to implementing these methods in actual, bedside patient care. Do you anticipate that these types of, diagnostic tools would have to go through FDA approval type of procedures, or can be implemented by uh, private companies without that?
Well, the way I see it is we want to use this as a companion, let's say, for a clinician, not as a replacement for the clinician. Remember, those models always can get something wrong. But if they tell you, hey, look at this patient, you can look at the data, you can evaluate the patient, right? But I don't
Mhm,
think this is to be used. I mean, we know that people is using ChatGPT as their personal therapist,
mhm.
but the model has not been trained for that, right? So yeah.
So, so potentially, for example, I'm just thinking about other types of digital health tools that they incorporate, for example, for cardiology or other medical fields. Would you
Mhm.
be able to implement something like this on, let's say, an Apple device, and the clinician would be able to use it in the long term?
Okay. So for example, for diabetes, now there are many automatic tools that measure constantly your blood, and according to that, administer more or less insulin or some drug, right?
Mm, mhm,
And even though that's complex, that in a sense is a mathematical function. So you measure something that is a real number, and then there is no room for interpretation, right?
mhm.
But with mental health, it's not so black and white. I mean, yeah. So I don't know how soon you will have a tool that is well. But let's be honest. Sometimes therapists also can make a mistake, and they can be distracted because they fought with their wife or I don't know what. So it's also not
Mhm,
100%, right? But and that you don't have with a bot.
mhm,
They are not tired, they are not distracted, but sometimes they hallucinate. So now we are working on a model that is, if you want, is an aggregation of different bots, and there is like a judge checking that there is no hallucination. So I mean, we are getting closer. The technology is already there, but I don't know how easy it will be for the FDA to approve any of this. But again,
mhm.
if you see it as a companion for a clinician, I think it's super, super useful.
Awesome. Thank you so much.
Any
Questions?
other questions? All right. Well, if there are no other questions, I think we might wrap up here. In the chat, everyone, we sent a survey that we'd appreciate if you filled out. It helps us plan for future events. And everybody, please give Dr. Norel a round of applause. This was very fascinating, and I think will really shape our field in the years to come.
Thank you. It was very nice to be able to explain what we are doing.